We're here in San Diego at the 2016 American Society of Hematology, and joining me this afternoon is Dr. Fonseca. Doctor, good to see you.
Thank you. It's my pleasure to be here with you.
It's an exciting time around multiple myeloma. It's an exciting time around cancer to begin with. A lot going on in immunotherapy, a lot going on in combination therapy, just so many breakthroughs that are happening that we're hearing about at this conference. Could you briefly describe for us the utility of gene expression in profiling for multiple myeloma?
Sure. Well, no, thank you for the opportunity before. You know, myeloma is a disease that we have the best biomarkers ever, so we've had them for a long time for disease diagnosis and monitoring. We have new biomarkers that tell us about depth of response, what we call minimal residual disease. And we also have markers that identify the biology of the disease. And I myself had the opportunity to work on the very first studies that were using genetics as prognostic factors. You know, back then FISH. I think that has been refined, and gene expression profiling is clearly one of the ways to do that better. In fact, we presented a poster about that where you show the power of gene expression profiling to identify characteristics of those cells that would tell you the patient has a more aggressive disease. And I think where the field is moving is that this is dictating what we're doing as far as treatment choices. And, you know, we don't have all the answers, but we know it has to be different depending on the different risk for patients.
So when we talk about profiling, we're talking about looking at big data, is that right?
Sure.
And lots of data from lots of patients and profiling this. How exactly does that work?
So the way it happens with the gene expression profiling platforms, you actually take a sample from the bone marrow, then you select and you test exclusively the plasma cells or the myeloma cells. There's different ways in which they can be enriched, but essentially they're enriched for that, so you have a pure product. They look at the level of RNA genes and how they are expressed, and fortunately a lot of this is automated now. You know, you put your chip where you can test 40,000 genes, you get this into the computer, and based on that data the computer will give you some results that we interpret as information. So we know which subtype of myeloma the patient has, how does that relate to prognosis and so forth.
And what's the relationship to, let's say, other modalities of risk assessment?
Well, this is a more modern one, and it's a very dynamic and functional one, so it really tells you not only of the subtype of the disease, but it can tell you about aggressiveness. So, you know, it will give you readouts for genes that will tell you that the cells are proliferating or they're more resistant to drugs. And again, you know, this is an improvement over what we did originally with the FISH results, which are still used in the clinic. They're considered standard of care, but this is taking it a step forward. And I should say this is different from mutation panels because mutation panels are static. All they tell you is whether a gene is mutated or not, and based on that, you predict maybe what's going to happen. But with gene expression profiling, you actually are looking at the behavior of the cells.
So that's interesting. So you're taking a snapshot in time. You're looking at that gene and you're looking at how it expresses itself.
Correct.
Not just a one-time snapshot view.
Well, that's if you repeat it, but you can see, I guess more what I mean is you can see the genetic signature, but then the consequences. So let me give you an example. If you have a genetic signature of subtype 1, and that subtype 1 is associated with faster growth for the cells, at the same time we look at the genes that classify as type 1, then we can look downstream at all the other genes, and for instance, all the proliferation genes are up, and that's how it's dynamic in its interpretation.
So when we look at this, the gene expression, how do we, when we look at the data and we look at all the analysis and all the research, how do we convert that into therapies for patients? You know, we're hearing a lot about personalized medicine now.
Sure.
And so I guess what we're talking about hits right at the heart of that.
Yes, of course. So and we have been doing that, but this is the next step to refine this and to take this to the point that we can more precisely tailor the specific interventions that patient needs. You know, you wouldn't go to a breast cancer conference and not talk about ER or PR status on the breast cancer, and we did that for many years in myeloma. Now that's moving into, let's talk about high-risk signatures. Maybe they need a different maintenance, maybe they need a different approach even for first-line therapy, and that's where this is moving, you know, tailoring and personalizing more to the specific signature of patients.
I see. So when we talk about high risk, obviously we're looking at a lot of patients, right, and getting a lot of data. So how do we look at the large amount of patients in relationship to the high hazard ratio, for example?
So the way this systems work, you actually look for those patients that have those signatures that will make them classify as high risk. And that is estimated, different studies, but just a number, sort of ballpark, is around 20% of patients. So
20% of multiple myeloma
20%
patients?
of multiple myeloma patients will fall into this high-risk category. And that, again, depending on how you measure it, can go up to 25 down to 15. But the bottom line is about 1 in 4, 1 in 5 patients has features that make us worry more about that myeloma. So when we see patients, this is really important for patient counseling. We go and we tell them, well, myeloma is great because we have all these new therapies, and we start talking about a chronic disease. If you have high-risk disease, that's unfortunately not a reality. And I think how we discuss that with patients and the hue that our conversation takes is quite different, because we have to be far more vigilant and intensive with the high-risk patients.
So when you say more intensive, so we're a more aggressive therapy, is that what we're looking at?
Sure, and depending on the specificity of the subtype within the high risk, that some drugs are a must-have. Perhaps one of the cleanest examples is that for patients who have high-risk disease, after stem cell transplant, standard maintenance approaches are not sufficient, so you have to intensify that with additional medications like proteasome inhibitors.
So this is where the combination therapies begin to come into play, I would assume.
Well, it's true. I mean, we're doing combination for most of the lines of therapy, except in maintenance is usually still a simple thing. But simple maintenance is not enough for high-risk patients.
Yeah, and so when we see a patient go on maintenance, do we see a lot of high-risk patients go on maintenance and then have a reoccurrence, or how does that work?
Yeah, the high risk would dictate that the patient is at much greater risk of having a relapse from their disease, say, after stem cell transplant.
Sure.
So that's why this is so important. It modulates how we react to that, perhaps even the frequency on how we approach things, and as I was mentioning, the drugs that we're using for treatment.
Well, Doctor, very fascinating time, very exciting work. Thank you so much for stopping by and spending time with us.
It's my pleasure, and thank you for the interest.
Thank you.